Good morning, everyone. My name is Nouf Samid Jardabi. I'm currently a surgical resident in Ibn Nafis Hospital at Kingdom of Bahrain. It's my pleasure to be presenting today in this conference. I'll be presenting one of my published research, which is seasonal variation in cases of acute appendicitis. Acute appendicitis is a common global acute abdominal surgical condition. Its etiology is poorly understood. Environmental factors have been implicated, including summer season, air pollution, and dust and allergens. Incidence is increased in certain ethnic groups and complications are increased in minorities, likely due to lack of healthcare access. Cases are classified into simple, non-perforated, and complex, gangrenous, perforated, and pelvic abdominal abscess. Bahrain is an archipelago in the Gulf with an arid climate. The year is divided into two seasons, summer, June to September, and winter, December to March. These are separated by two transitional periods, first, April and May, and second, October and November. Our objective was to investigate whether the incidence of acute appendicitis increases in summer season, and to assess whether the incidence of complicated appendicitis increases in summer season compared to other seasons. Methodology. This is a single-center cross-sectional retrospective study conducted by the Department of Surgery in Salmonia Medical Complex. Salmonia Medical Complex is the largest hospital in Bahrain, a 1,029-bed tertiary hospital in the capital Manama, serving all citizens and residents of all ages. The study was conducted on 697 cases admitted to our facility with a clinical diagnosis of acute appendicitis in the year 2018. Approval of the Institutional Ethical Review Board was attained on 6th of July 2020. The patients were selected, as stated previously, from those admitted with acute appendicitis based on clinical and/or laboratory imaging diagnosis in the year 2018. Inclusion criteria included patients admitted with a diagnosis of acute appendicitis who underwent appendectomy, open or laparoscopic, of all ages, including those admitted under pediatric surgery. Exclusion criteria included conservative management, for example, appendiceal mass and other clinical diagnoses. Patient data was collected from the National Health Information System, iSahha. The study did not involve any patient intervention or contact. Seasons were divided as previously mentioned into winter, January to March, December, first transitional period termed as T1, April and May, summer, June to September, and second transitional period termed as T2, October and November. Data on the mean monthly temperature was obtained from the official website of the Ministry of Transportation and Telecommunications in Bahrain, Civil Aviation Affairs. Biostatistical analysis was performed using Microsoft Excel software for Mac with Analysis Toolpack version 16.38. A chi-square p-value of less than 0.05 was considered statistically significant with a corresponding confidence level of 95%. Pearson correlation coefficient was calculated to assess the correlation between the monthly incidence of acute appendicitis and corresponding mean temperature recorded in each month of the year of 2018. The results were as followed. Out of 697 patients, 51 were managed conservatively and thus excluded. A final total of 646 patients were included in the study. Patients were evaluated by history taking, physical assessment, laboratory investigation, and radiological studies as indicated. Ages ranged from 3 to 77 years. Among these, males comprised the majority, 500, which is 77.4%, compared to 146 females, which is 22.6%. In concordance with many studies, the majority of our patient population were males, accounting for 77.4% of the study population. About 47.4% of the patients originated from Southern Asia countries, India, Bangladesh, Pakistan, Nepal, Sri Lanka, while 40.9% were Bahrainis. Other ethnic groups and demographic data are demonstrated in Table 1. Final histopathological examination categories are demonstrated in Table 2. Gangrenous, perforated, and purulent appendices were regarded as complicated appendicitis. The highest number of cases were registered in summer, 234 cases comprising 36.2% of all cases, while 203 cases were admitted in winter months, which is 31.4%, 106 cases in T1, which is 16.4%, and 103 in T2, which is 16%. Complicated cases were equal to 65, of which 35.4% were admitted in summer, 46.2% in winter, 10.8% in T1, and 5 in T2, 7.7%. The highest number of cases was during the month of July, 68 cases, while the month with the lowest number was February, which is 40 cases. This corresponds to the highest recording mean temperature, 36.2, and the second lowest, 19.8, respectively. Pearson correlation coefficient was calculated and revealed a moderate positive correlation. Pearson R 0.5183, R2 coefficient of determination 0.2686, p-value 0.084292 between the monthly incidence of appendicitis and the corresponding recording mean temperature in that month. We further investigated the variables related to complicated appendicitis, namely the ethnic group. The highest groups representing with complications were Bahrainis, 23, which comprises 35.4%, and Southern Asia, which is 27, which corresponds to 41.5%. Another studied variable was the duration of symptoms at the time of presentation. 2 patients were excluded from T1 group, 5 from the summer group, and 2 from T2 group due to lack of documentation. For the rest, it was noted that the average time at presentation was 2.03, 2.2, 2.06, and 4.3 days following the onset of symptoms in winter, T1, summer, and T2 group, respectively. Our findings are in line with other studies which address this issue in Canada, United States, South Korea, Iran, Italy, Taiwan, Pakistan, Finland, China, and the United Kingdom, which suggested a moderate positive correlation between the mean temperature and incidence. On the other hand, a study conducted in northern Saudi Arabia revealed an increased incidence in spring months, which coincide with the sandstorm season. This might be attributed to dust and allergen burden to the lymphoid tissue. In other areas like Nigeria, Turkey, certain parts of the United States, and the United Kingdom, different results were obtained. For example, in Nigeria, appendicitis was more common in the rainy season, which is known for humidity, allergens, higher rates of bacterial, viral, and intestinal parasitic infections. So what's the reason behind the observed increase in incidence of appendicitis in summer in many countries? One of the studies have suggested that the exposure to air pollution was noted to trigger the occurrence of appendicitis, particularly in men during summer season. In a study conducted on pediatric age group in Taiwan, it was noted that the percentage of appendicitis cases with fecal death in summer was lower than other seasons. This was attributed to lymphoid hyperplasia, which may be associated with the outbreak of enterovirus during this time of the year. Another research have proposed that pediatric appendicitis cases were associated with higher temperature, lower humidity, and less sunshine. Dietary habits in summer might play a role as well. Studies have suggested a role for dehydration and less bowel movement in summer. A review by Forrest has stated that the increased consumption of low-fiber diet and sugar in summer, particularly when individuals are likely to be out, can lead to constipation and subsequently to appendicitis. Alcohol consumption is reportedly highest during summertime and has been linked to constipation. Though in our part of the world, alcohol consumption is forbidden and restricted for religious reasons. Another key factor suggested by Forrest are the infectious agents implicated in appendicitis through causing lymphoid hyperplasia and resulting lumen obstruction. Summer peak of infection caused by agents such as Campylobacter, Salmonella, E. coli, Entamoeba histolytica, Ascaris, Tinea saginata is noted in some countries. In our study, only 2 cases were found on histopathological analysis to have helminths presented and operated in the month of January and May. Both were found to have nematodes. We note that 47.4% of our patient population originates from South Asia. They tend to work as laborers in industries and might be exposed to air pollution and spend many working hours outdoor in the sun. We believe this might play a role in the disease. Through our study, we also aim to investigate whether complicated cases presented more in summer months. However, out of 65 complicated cases, we found that only 23 cases, 35.4% were admitted in summer, 46.2% in winter, 10.8% in T1, and 7.7% in T2. In conclusion, in line with other studies, more cases of appendicitis were noted during summer months. The monthly incidence correlated positively with the mean temperature. Larger numbers over several years might be needed to be studied to draw better conclusion on our patient population and even reach the possible causes behind such variation. Thank you very much. Any questions?